डॉक्टर्स का सबसे भरोसेमंद सैवलॉन एंटीसेप्टिक लिक्विड है कोविड-19 कोरोना वायरस पर असरदार।
Hello and welcome to another edition of Expressions, brought to you by the New Indian Express in Savlon. I have with me Dr. Satyajit Rath, one of India's premier immunologists, and we're trying to understand from him this wicked nature of this virus. You know, how has it, and how have doctors also seen it over the last few months? How has it behaved? It's a real trickster, isn't it? It seems to defy understanding, logic. 1 minute we're told plasma therapy could work. The other minute we're told, too many steroids are bad. Too many antibiotics are also not good. Then there's something called the black fungus, then the white fungus. It is quite mind-boggling. And I think in the current anti-science environment, unfortunately, where even basics of medical care are being questioned by our so-called leaders, it's a very worrying scenario. How, Doctor, I wanted to understand from you, because we'll come to, of course, some of the things that you've talked about, which are quite fascinating, like you've talked about physical distancing, but social solidarity. Those ideas are quite fascinating. But first, could we just spend a little time trying to understand how has this virus behaved over the last year and a half?
It's interesting that we tend to think of this virus as something unusual or extraordinary, but in reality, it isn't. It's really what virus populations have happening to them. In virus populations, viruses tend to infect certain host species. And in that process, they become sort of specialists at infecting that host species. And if that happens, then the flip side of the coin for the virus populations is that they become not so good at infecting other species. Right. Effectively, therefore, viruses that infect bats, stay in bats. But because viruses are growing and replicating, they're making copies of themselves. And when that happens, there's always the chance of error. And miscopying leads to variations in the virus population. Every once in a while, one of those copies has a consequence. So some of those changes allow a bat virus to begin to infect human cells. Right. And that's how viruses sort of make these virus populations undergo these jumps between target species. Right. Yeah. Not as if viruses are thinking about any of this. These are natural processes. The interesting thing about this virus, SARS-CoV-2, and the disease it causes, COVID-19, is a peculiar coupling. It comes in through the breath. So it infects primarily cells in our throat, in our lung passages and lungs themselves. So locally, virus infections get set up. Promptly, there is an immune response that attempts to contain the virus infection right there in a little microcontainment zone. That's what we call inflammation. Inflammation is both useful because it provides for containment and antiviral activity, but it's also problematic. It's a double-edged sword because it causes local tissue not to function quite as well. There is swelling locally, there is oozing. If there is enough oozing, then there is fluid in the lungs, so we can't breathe. If there is swelling and oozing in the throat, then we are coughing. The inflammatory cues that the system uses sometimes spill over and cause fever. So a lot of the symptoms of the disease are actually not the virus, it's the immune response
the body responding
as
to
it
it. Right.
as it functions to limit the virus, it's also causing
Right.
a certain amount of problem. The
Right.
curious thing that we still don't understand about this virus is that in the majority of cases, this is all that happens. There is local infection in the airways. The virus grows a little, the virus in this infected person gets thrown out and therefore gets transmitted. But the immune system of this person contains it, makes inflammation, makes antibodies against the virus, limits the virus numbers, and eventually gains control. And you're better. 70,
Right.
80, 90% of the times when we are infected, this is what happens, apparent, as far as we can tell. In a small minority of cases, 10% odd, the inflammation is so much that the lungs fill with fluid.
Right.
And that's inflammatory fluid. That's not the virus making fluid. That's our immune system making fluid.
Right.
So it's in those cases that we still don't quite understand what separates those with mild or moderate illness from those with severe life threatening illness. What is different between people who have mild COVID 19 and people who have severe COVID 19? We really don't understand. We do know that age, other so called comorbidities, all of
Morbidities. We have
these
covered all that.
increase the chances, but we don't understand exactly how they increase the chances of severe illness.
Oh,
So that's something
okay.
that we still do not understand. And it is important for us in pandemic times to keep in mind that we've been studying this disease only for a year and a half. We
That's
don't
right.
know a great deal about it. To be excessively certain about anything to do with this disease is to risk being horribly wrong. So we need to be careful and cautious. And we need to remember that on the one hand, we need to understand how this works in order to get over it. On the other hand, we're not going to understand it overnight. We're going to have to live with the uncertainty for a while.
Right. And Dr. Rath, you've been studying TB for the longest time, if I'm not mistaken. How are these, how is that different from this? And how have the, a lot of, from what I also understand, a lot of the a lot of the vaccine development that took place for this virus was in process earlier, but perhaps it was directed towards the HIV virus. Is that so?
Yeah.
Have we seen any kind of similarities with the diseases we've lived with so far?
So let me answer your last question first. Very much. In fact, everybody is worried about how did vaccines get made within a year? Isn't this
Exactly.
quick? Have they taken shortcuts? Are there risks? And so on and so forth. And the real mundane, ordinary answer is that these vaccines have been made for the past 20 years. This virus has
Yeah.
relatives. It's a member of the coronavirus family. The coronavirus family is a large family of viruses. One of its relatives we met 20 years ago is called, it caused a disease called SARS. Another we
Right.
met 10 years ago. It caused a disease called MERS. What
Right.
was similar between these three diseases is that all three of them are respiratory.
Right.
But there were two things that were not similar between SARS 20 years ago, MERS 10 years ago, and COVID today. And that is, if 5 people were infected with the SARS or the MERS viruses, 1 or 2 died.
Right.
If 200 people get infected with today's virus, maybe 1 or 2 die. Today's virus is much less individually dangerous and lethal than SARS or MERS were. This is one difference between them. But the second difference is instructive because it says something about vaccines. So you can imagine that 20 years ago, as well as 10 years ago, when these diseases, SARS and MERS, came onto the scenario, research groups across the world began trying to make a vaccine. Because making vaccines against these sorts of viruses is relatively, scientifically speaking, not as difficult as making a vaccine against TB or HIV is.
Right.
So they began making vaccines. They began testing vaccines. They began finding all the preliminary data that said vaccines seem to be safe. Vaccines seem to have some reason to expect effectiveness and efficacy and so on. But by that time, we discovered the other difference between those two viruses and today's virus, which is those two viruses didn't spread very well.
Right.
Today's virus spreads incredibly efficiently.
Yeah.
Because those viruses didn't seem to spread terribly efficiently, simply maintaining some amount of physical distancing wherever there were outbreaks nipped them in the bud. Transmission stopped.
Right.
And because an ordinary step like local physical distancing stopped transmission, there were no large scale, huge outbreaks, there was no pandemic.
Right.
And as a result, we decided the world over, whether right or wrong, all of us should think about. But we decided that therefore we didn't need those vaccines. More correctly, all of those vaccines, like today's vaccines, even though they were developed in public sector research institutions, universities, and laboratories, were being developed by the private sector.
Okay.
And for the private sector, if there wasn't a large-scale epidemic, nobody was going to buy their vaccines, so they stopped developing it. So these prototype vaccines that had already come to a certain distance went back on the shelf 20 years ago, 10 years ago. All that happened last year was that all of those researchers took them off the shelf, dusted them off, made small differences in them because the three viruses are related, but they are a little bit different. So made the little difference change in the vaccine design, and hey presto, we had a new vaccine. But this time we needed these vaccines because the virus spreads efficiently.
Right.
And therefore, despite the fact that it is not a terribly lethal virus, it's a societal risk. It's a societal risk because, as we've seen simultaneously, if huge numbers of people get infected, then even the small percentage of people who get serious illness, those numbers become so large that the medical system gets overwhelmed.
Absolutely.
What we have seen these last 2-3 months.
Right.
So that's why we've needed the vaccine. But that's therefore the story about all the current vaccines.
Right.
And there is the difference between how tuberculosis or HIV as infectious diseases work versus how these respiratory coronavirus infectious diseases work. And that's why these vaccines are in many ways simpler to visualize and to design than vaccines against TB or HIV.
Right. What is the process of those? Are those also currently being developed? Are they at some point of fruition? What is the state of those?
Well, keep in mind that one of the oldest vaccines that we have is the tuberculosis vaccine. BCG vaccine goes very far back. So it all depends on what you want to prevent and where you want to prevent it. As a general approximation, BCG as an anti-tuberculosis vaccine seems to work quite well in countries of the global north, in what we generally refer to as developed countries or prosperous countries or rich countries or whatever one wants to call them. Not so much in countries of the global south. In poor, underdeveloped or developing countries, there are some countries where BCG trials show no protection. There are some countries where they show protection. In India, for example, there's an even more peculiar separation. BCG provides quite good protection against severe acute tuberculous meningitis in children. So to that extent, is it a good vaccine? Does it prevent a particular disease? Yes, it does. But does it prevent the familiar chronic respiratory lung tuberculosis Not very well.
Okay.
And this seems to be because the tubercle bacillus, which is a bacterium, not a virus, it grows much more slowly. It's got many more interfaces with our bodies, and
Right.
therefore many more diverse outcomes of those interactions with our bodies, and therefore quite different mechanisms and a whole complex landscape of mechanisms operates in tuberculosis as opposed to something like COVID 19. Now,
Hmm.
even though I'm saying COVID 19 is relatively simple, that's only relatively simple.
Hmm.
And even so, we've been looking at it only for a year and a half.
Exactly.
We really don't know many things about it. We do know enough things about it to have come to the point where we know that a vaccination program will work to
Right.
bring some control to the spread of infection. We know enough about it, as I said, to figure out that initially the virus grows, the immune response follows, but eventually the immune response gets the upper hand and the virus amount begins to go down. At this point, early, because the immune response is trying to catch up and control the virus, if you use medications that suppress the immune response, such as steroids, then you are likely to cause more harm than good.
Right.
On the other hand, if at a later stage the immune response is still causing damage, even after the virus has been kind of brought under control, at that stage, if you use steroids, you might actually improve the illness without causing any further. So, steroid treatment, I mean, this is something that Professor Guleria of the All India Institute of Medical Sciences has been pointing out. It depends on where you use steroids. Too early usage is not a good thing
Hmm.
because you repress the immune system.
Right.
Steroids tend to suppress immune responses. You suppress those immune responses for too long, and many other very sort of low efficiency microbes in our environment, such as mucor or aspergillus or candida, all these fungal infections that are cropping up, usually they don't cause any problems for anybody except people who are deeply immunosuppressed.
Right.
But if we give patients steroids for very long periods of time, patients of COVID-19, steroids for very long periods of time, then we are risking all these other infections, which is where these other infections are coming.
Are coming from. Right. What is the sense on the use of antibiotics? Those overuse of those, as in any other disease, is also a problem.
Is certainly a problem. And again, this is something that clinicians and clinical academics have been pointing out for a long time.
Very long time.
The point again is, should we be using antibiotics? Let me speak about this in the COVID 19 context. Should we be using antibiotics for COVID 19? Well, COVID 19 is caused by a virus. Antibiotics have no activity against viruses. So
Right.
the short answer would be no. But as I said, COVID 19, like many other viral infections, even ordinary cough and cold infections caused by viruses, cause local inflammation. Local
Right.
inflammation leads to fluid collecting here, there in the lungs. And in those areas, other bacteria can now come in and grow there. So
Okay.
that's a secondary infection. And to
Right.
control that, we would need to use antibiotics.
Right.
But really, we should be using antibiotics with care as and when individual patient conditions and findings make them appropriate, rather than simply, oh, so and so is COVID 19 test positive, give them steroids, give them antibiotics, give them fever reduction, give them something for the cough, give them ivermectin, which is a medication that has absolutely no proven utility whatsoever. We've this sort of one size fits all approach that we have out of panic begun to take is creating problems for us.
Right. And plasma therapy, doctor?
So let me explain a little bit of background again. As I said, initially the virus grows.
Right.
the immune response is trying to catch up. At that point, early during the illness, the symptoms are mild. As the immune system catches up, depending on just how long it takes to catch up, so that the virus amount is really large, so the immune response is really large, it begins to get the virus under control. But by that time, the damage beginning to be caused by the immune system is quite a bit. That's the point at which we admit patients to hospitals. It is only when we admit patients to hospitals that we can give intravenous medication. Currently, plasma therapy is therapy that can only be given as intravenous medication. Here is the problem. With plasma therapy, what are you giving? You are giving antibodies which will stop viruses from growing further.
Right.
But at that point, when you can give them in a hospital, people are in hospital because they have a lot of inflammation, not because they have a lot of virus.
Yeah.
In fact, in all likelihood, the virus is already coming under reasonable control. It's the inflammation that needs to be.
Right.
At which point, in many of those people, the plasma therapy, even if it worked, would be besides the point.
Right.
Added to this is the other problem. And the other problem is, see, I get infected, I recover, I have antibodies, and therefore I can, in theory, give plasma. The problem with that is, we don't know how much good, effective antibody I have made.
Right.
We don't know how much good, effective antibody needs to be transferred into a patient in order to have any effect.
Right.
So we are therefore effectively simply indulging in wishful thinking as far as most of plasma therapy is concerned.
Yeah.
Will it work in the occasional patient? Sure. Will we ever know? No, because we are not doing it as a trial. We are not properly measuring antibodies. We're not properly measuring virus. We're not properly measuring outcome. And when people have done trials systematically, those trials have not shown any major utility of plasma therapy. And this is the background and the science why, in all likelihood, that has not happened.
So fascinating. So we know all these things, and yet we have come to a point where we're still struggling after more than a year and a half. I understand that we don't know enough, but we're still struggling with these ideas and with these practices. So is that because we don't have enough to counter it? Therefore, whatever we can, we do, or is it just out of plain ignorance?
Let me put it this way.
Because no doctor wants
What
to.
did-
Yeah.
What did we know last year? We
Yeah.
knew that much of what I have said, we knew by the end of the first couple of months.
Right.
So, did we know anything about how to treat patients? Yes. Did the clinicians exchange across the world a great deal of information? Yes. Initially, patients were being put on ventilators. Eventually, within weeks, the outstanding clinicians the world over figured out that just providing high pressure oxygen without ventilator machines was helping. Outstanding nurses and nursing aides. You see, we don't give enough credit to
Absolutely.
our healthcare workers. They figured out that just turning patients, because there is fluid in the lungs, using gravity to allow the fluid to drain was helping enormously. So a lot of nursing practice and treatment protocols were developed within the first few months that have been in use all this time. We knew all of this. What did we need to do? We needed to acknowledge that COVID-19 and the pandemic is not a short-term crisis. It's not like an earthquake where it has happened. Now all we have to deal with is the aftermath. It's going to keep coming up and going down and coming up and going down because it's a matter of spread. So it's going to be with us for a year or two. We need to provide healthcare facilities with adequate amounts of resources in decentralized fashion, because it's going to spread eventually everywhere. You can't be carrying patients back and forth. And we should not be doing doing it the way we've been doing it. Again, not simply in India, the world over.
Right.
But I'll give you India's example. We have been setting up COVID centers and we've been recruiting them with people employed on a 45-day contract, on a 60-day contract, on a 30-day contract, as though within that period of time the problem is going to be over.
Right.
We needed a much more careful understanding that this is not that kind of an acute disaster crisis, that for the next couple of years, we are going to have to deal with this uncertainty of outbreaks somewhere. We are going to have to make commitments at the state level, at the government level, financial commitments, resource and facility commitments, some of which may well be wasted because there won't be an outbreak. But when there is an outbreak, we should not be wanting in the resources that are necessary. This is one thing we did not do. The other thing we did not do, and I call you to witness, is we knew last year that this is a respiratory virus. You've heard all this debate about is it droplet or aerosol and so on and so forth in transmission. But the reality is, we know that this goes from one person to another person via breath.
Right.
You know, I keep quoting poor Kabir inappropriately on this. I keep saying it is sab sanson ki saans mein.
Right.
And the reality is, we knew last year what to do. We knew that we needed to do physical distancing.
Right.
We knew we needed to wear masks. We knew that the better our mask filtration capacity was, the better protection we would have.
Right.
Let me ask you a question, or two questions. One is, if you go to the market, how many people are actually wearing masks appropriately, particularly when they speak? How many people do you see just here and there who are wearing masks? Most people are wearing masks here.
Yeah.
But even when they are wearing masks properly, who pull the mask down to talk to each other?
Which is the worst thing.
But what are we doing? So, but I'm not just faulting us as individuals in society. I'm also faulting our government as representative leadership. Did we embark upon a sustained, strong, community-empowered campaign to explain this so that it became a cultural norm? The kind of physical distancing and social solidarity that I keep talking about? No, we didn't. Instead, we indulged in all sorts of Indian exceptionalism and triumphalism.
Yeah, and Vishwaguruism.
But let me ask you another question about masks, which is kind of scientific. All this stuff about what size of droplet is more dangerous or less dangerous. And the reality is, depending on circumstances, all droplets are going to be dangerous to some extent in transmitting disease. So here's the problem. Over the past year, the one thing we've done is, to some extent, we have managed distancing. What that has done is, it has put pressure on the virus population, because the virus is not getting transmitted as efficiently as it was initially,
Right.
because we are distancing. What sort of variation in the virus population has gotten an advantage to grow as a consequence of this? Those variations that allow the virus to transmit better.
Right.
Because when transmission has become difficult for the virus population, those elements of the virus population that transmit better will still continue to be transmitted and will therefore grow. All the variants that we are talking about the world over, see, remember, variants have emerged everywhere.
Right.
This is not, we should never be using geographical identifiers for variants.
Okay.
The government of India has been complaining very loudly about this, and it is correct.
That is correct, isn't it?
Yes, but let me point out that the Press Information Bureau of the Government of India repeatedly uses UK variant, South African variant, Brazilian
We have to
variant.
be reciprocal
what
about
is
these
sauce
things.
for the goose does not appear to be sauce for the gander as far as the Government of India is concerned. But that aside, the point is quite correct that we should not be using geographical nomenclature. The fact is, these variants will emerge in every community, because it's what will happen when we put pressure on the virus population
Yeah.
by distancing. Those that are a little bit better at transmitting are the ones that will survive and grow. The point there is, what should be our response to this? We should be masking a little bit better. Over the past year, have we done anything about a fundamental problem, which is that for the bulk of India's population, masking has simply meant tying a dupatta around your face?
Absolutely.
And we know that that's not adequate.
Right.
What should we have done? We should have come up with sustainable, environment friendly N95 mask development technologies. We should have put them out into the public domain. We should have made them available as a matter of public health care.
Big healthcare, yeah.
We haven't done anything of the sort. The second thing was, it was bound, everybody was making vaccines by last April, May. There were already 100 groups. So it was very clear that by the end of the year, vaccines would be available. We needed to fast track vaccine processes, not fast track vaccines, vaccine processes. We needed governments to say, we will carry out vaccine trials. We will carry out vaccine trials in parallel. We will set up vaccine manufacturing processes in parallel, even if some amount of money is lost because the vaccines that we set up manufacturing for actually don't succeed. Okay, we lose some money. But those are the sorts of risks that governments should be taking in a pandemic. Did we do any of this? No, we are doing it now, today, belatedly.
Yeah. It's way too late.
Well,
But it still has to be done.
Nothing is ever too late.
Too late.
Is it good that we are doing it now? Yes, it is.
Of course, yeah. Right. It seems so simple, Dr. Rath, when you explain it like this. And I'm sure it's been explained to our political leadership as well. What is it not listening? Is it not looking at science? Is it not looking at evidence? Is it not listening to the right advice?
Part of it is, I think, that when we are afraid, we desperately look for certainties. And the kind of science and the kind of evidence-based explanations that I'm talking about really don't provide certainties. Let me give you the obvious example of vaccination. Is a vaccine going to protect me? If I take the vaccine, am I going to be protected? The answer is not yes or no. The answer is, I'm going to be protected to a certain degree.
Right.
But that's no answer for the individual.
Right.
You see, what happens is, how do I determine whether the vaccine is protective, useful or not? We've tested that the vaccine is safe. Now, what we are trying to test is whether the vaccine is protective or not. We take 10,000 people without vaccination, we take 10,000 people with vaccination, and simply month by month, we count the number of COVID-19 cases in these two groups. So first month, there are 10 cases here, there are 3 cases here, we say, oh, 70% effective. Second month, there are 50 cases here, 10 cases here, we say, oh, 80% effective. Third month, there are 1,000 cases there, there are 300 cases here. You say, oh, it went down to 70%. The reality is, all that this is showing us is that the vaccine is effective. It's reducing numbers substantially. Do we know exactly by how much? No, we are going to have to wait for the full year of the vaccine trial in order to come up with reliable numbers.
Right.
But all of this is a matter of measured risk of statistics. The problem with this is, as many of my health activist friends say, you're not pointing out that vaccines are only 60-70% effective, even in trials. So in reality, they'll be only 50% effective. And my problem is, all of these numbers are tentative.
Yeah.
All that we know is that the vaccines are quite safe and that they are reasonably effective. And therefore, as individuals, we should all be taking them.
Right.
But at the state policy level, they still provide for ambiguity, because they don't say how much of the population will be how much protected. because the numbers are still uncertain. What this allows people in leadership, especially people tasked with spending money, is, do we have to spend this much money? Are you certain that there is going to be that much of return if we make this much of investment? What if there isn't? What if the disease doesn't grow? I'm sure by last December, January, this was the point. Oh, India is exceptional. India is unique. India has controlled infection very well. We don't need to worry about it. Then why should we be spending money on it? And this is exactly how communities have responded as well, in part because the leadership has given these signals, in part because all of us have our own harried lives to live every day. We can't be worrying about a disease that we may or may not ever see. As the people walking back last year during the lockdown said repeatedly, विषाणु तो दूर की बात है, भूख से आज मरने की बात खड़ी हो.
Exactly.
Whether I will die of the virus or not, I don't know, but I am quite
Definitely die of hunger.
So in all this, therefore, we tend to shrug and say,
ठीक है. It's amazing. And I believe that is the kind of vaccine hesitancy that is now being transmitted down the line, even to our villages. And people are actually, I was told such a shocking thing the other day, doctor. I don't know how true it is, but by someone who's actually spent some time there, that in some villages of UP in Barich district, they're likening the vaccine centers to the sterilization centers of the Sanjay Gandhi era. That's really worrying, isn't it? Because they feel that the women will become infertile, the men will become impotent. That level of, thinking is so worrying.
Firstly, it's a fascinating study in sociology or anthropology.
Yeah.
Because on the one hand, this whole notion of how vaccines cause sterility, etc., goes back to anti-science, anti-vaxxer movements in the global north.
Right.
And from there, it has crept via social media into our WhatsApp-based
knowledge-based
vernacular discourse. So that's interesting. Of course, there is no truth to any of this.
Yeah.
Let me point out how insidiously patriarchy works.
Yeah.
So think about what the problem is. With women, the problem is sterility. Men, the problem is impotence. And so with women, it's about whether they can bear children or not. With men, the problem is whether sexual performance is held up or not.
Amazing.
Patriarchy works in extraordinary ways. Of course, all of these are nonsensical. It astonishes me that this has so much traction in a country where between 5 to 10 crore children are vaccinated in the universal immunization, childhood immunization program every year with a whole portfolio of vaccines.
Right.
Starting from the first day of birth.
Yeah.
We give vaccines. And in that portfolio, we give vaccines that are 40% effective, 60% effective, 70% effective, and so on and so forth. We know that they are safe and that they provide some reasonable measure of protection. It's always useful. And that brings me to my point about vaccination, which is it has an individual protection component. I should take the vaccine so that I am protected to some extent.
Right.
But I should also take the vaccine because I am therefore cutting down on the likelihood that I will be transmitting this to other people.
Right.
And therefore, this is both an individual risk reduction strategy and a societal responsibility as a good citizen.
Thank you for pointing out that the virus is not sentient. It's the way we respond to it that is the point. Thank you very much, Dr. Dutt, for a wonderful discussion.
Likewise. Thank you very much.
डॉक्टर्स का सबसे भरोसेमंद Savlon एंटीसेप्टिक लिक्विड है कोविड-19 कोरोना वायरस पर असरदार।